Hello, everybody. This is Mark Dlugoss, Senior Contributing Editor for Ophthalmology 360. Welcome to the Ophthalmic Project, powered by Ophthalmology 360. As you may or may not know, the Ophthalmology Project is a series of blogs and podcasts that addresses issues facing in ophthalmology today by offering observations and interviews with the shakers and movers in the ophthalmic field. Today, the Ophthalmic Project continues its coverage about thyroid eye disease with a panel discussion on the disease and to report on new findings that were presented at the 2021 American Academy of Ophthalmology. Joining me now is a panel of experts on thyroid eye disease, and they are, first of all, Raymond Douglas, who is Director of Thyroid Eye Disease Program at Cedars-Sinai Medical Center in Los Angeles. Andrea Kossler, Associate Professor of Ophthalmology at Stanford University in Palo Alto, California. And Erin Shriver, Clinical Professor of Ophthalmology and Visual Sciences at the University of Iowa in Iowa City. Doctors, welcome to the Ophthalmic Project.
Thank you so much.
Yeah. Thanks for having us.
Yeah. Thank you.
Glad you could make it, spend some time with us to talk about this pretty interesting disease that you're facing more, and some of the new things that have been coming through that appeared recently regarding the disease. First of all, I want to start off with a pre-panel discussion. We'll get down to some individual things later, but I'd like to talk about the current state of thyroid eye disease. Basically, look for how many patients there are, some of the symptoms of the thyroid eye disease, the phases involving the disease, and we'll proceed from there, starting with that question.
So I think it's one thing that's really important is to put thyroid eye disease in the context of autoimmune thyroid disease, which tends to be one of the more common autoimmune conditions. And then thyroid eye disease is a subset affecting patients with Graves' disease, probably about 50%, and also patients who have Hashimoto's, much less, probably about 10%. So this number of patients afflicted with this disease is significant, and certainly something that is really we confront with every day in our ophthalmic community all the time.
You know, it's interesting. I got asked to write a piece about thyroid eye disease for the rare eye disease issue with the Indian Journal of Ophthalmology, and I said, rare eye disease, thyroid eye disease is not that rare. We see it all the time. You know, it's about a quarter to of our practice. But I realized what a sense we have in oculoplastics. Obviously, we have a warped sense of the rarity of it, or how common it really is. But it really is the most common orbital disease in US and Europe. And so it's something that we see in our practice often. I think it's going to be interesting now to see if the rates are higher if we look at the data coming in, because there's such an increased awareness about thyroid eye disease. I'm really interested to see the next study that comes out on prevalence of it.
That's interesting that you mentioned that, Erin. Of course, I'm sure everyone's working on all of these things at the same time, but that's a question that we have here at Stanford. But to give the viewers an idea of the prevalence, we know that hyperthyroidism occurs in about 1% to 2% of the US population. Graves' disease is probably less than that, maybe 5 in 200 patients, or 0.5% of the population. And we also know that about 50% of patients that has Graves' disease has the eye disease. So to give you a sense, we're looking at, from previous studies, about maybe 0.5% of the population, maybe a little bit less than that, can have this disease. I agree with you, Erin. That was when it was going undiagnosed. Now that there is this educational campaign that has been out there since 2020, and all of this awareness, the numbers of patients that I'm seeing with thyroid eye disease has skyrocketed. I'm sure it's the same for both of you and for all oculoplastic surgeons. And so the good news is that we are diagnosing these patients more often and earlier so that we can provide proper treatment.
It's also going to be interesting to see if that male-female ratio stays about the same, that 3 to 5 women per men, because in some sense, women tend to be a little bit more observant of their eyelid position, the position of the eyes themselves. And so it will be really interesting as more awareness is out there, if that is changed a little bit.
Well, let me ask you about this, doctors. Can you offer some understanding and management for the disease?
For an everyday clinician, so if we're talking about primary care doctors, I think sometimes if we don't think about the condition, then we're going to miss it. So in patients who are having eye pain or redness or swelling of their eyes, if they're having bulging of their eyes or a change in the symmetry or the appearance of the eyes, or even if they're having double vision, In those patients, especially if they have a history of hyperthyroidism or Graves' disease, you want to at least think about thyroid eye disease and send them to an ophthalmologist. For an ophthalmologist or an oculoplastic surgeon, we look at things very differently. If we think that patients have thyroid eye disease, we look for the classic symptoms like proptosis, eyelid retraction, double vision, eyelid swelling, pain, and redness. And then we try to classify these patients based on the activity of the disease and the severity of their disease. And so most patients with thyroid eye disease are going to go through some type of an inflammatory phase or some type of an active phase where their symptoms will develop and they may worsen. And if they have new onset symptoms, or if they have fluctuation in symptoms, or if they have orbital inflammatory signs, then we would consider them active. And this is kind of the older teaching, but still we consider these patients active. If they instead have more stable symptoms, things are not changing, things have been stable for months and months, but they do have either proptosis or eyelid retraction or double vision or some type of tissue remodeling from this disease, we would consider them either chronic or stable. We also want to figure out the severity of their disease. Do they have mild eyelid changes, mild proptosis, mild soft tissue changes? Do they have moderate, or do they have severe changes to their eyelid and to the tissues around the eye? And then also we want to make sure they don't have sight-threatening disease. So we try to diagnose the activity and the severity of the disease, which helps us to guide therapy.
The traditional teaching, as Andrea mentioned, is we would treat them during that active inflammatory phase because most of our medications have been anti-inflammatory in nature. So we would try to treat them in that phase and kind of hold their hand and console them through the process as the disease is taking its toll on their eyes and on their body. And then once they were stabilized, we'd kind of clean up what was left over. And so it's been really fun over the last couple of years to see that transform and to see our whole paradigm shift in how we're going to treat these patients. And potentially we might not have to, we all are now thinking we aren't going to have to wait through that process the entire time to watch it take its toll until it's stabilized.
What are the basic treatment options for thyroid eye disease? I know we've got a new drug and we're going to discuss, but what are the other options that were available before this drug became available?
The mainstay of therapy traditionally has been if a patient needs more than just, topical eye drops, lubrication, that kind of thing. The mainstay of therapy has traditionally been steroids, both oral, and then the studies had shown that IV steroids and post-IV steroids was more beneficial. The issues with steroids, however, are they treat just the inflammatory aspect of the orbital process, and they're about 60 to 60% in oral, 70% in IV. Effective, and there's a lot of rebound and there's a lot of side effects from the steroid themselves. Also, they don't treat the proptosis necessarily, as well as some of the lid retraction and strabismus. So they don't really treat the process. It's kind of a band-aid on the inflammatory aspect of the disease. And so other things have been looked at. Radiation, for example, is used when there's active inflammation. Of course, it's limited in what patients we can use it for because of the teratogenic, the carcinogenic effects of the radiation. And then other medications like biologics, rituximab and tocilizumab have been looked at. The randomized controlled trials are kind of equivocal with rituximab. There's one that's beneficial, one that says it's not as beneficial. Tocilizumab, we have some studies that's shown that they were beneficial, but we don't have good randomized controlled trials. And again, those are looking more at the inflammatory aspect of the disease instead of targeting the disease itself. And that's what's been exciting about the FDA-approved new drug Teprotumor, which actually targets the receptors involved with thyroid eye disease.
We've spent a lot of time, just as Erin was saying, looking at the immune response, but there's going to be there's a lot more to it than that. So any combination of immune mediator that impairs the immune system has been examined with limited efficacy as far as reversing the disease. And so, we're really looking forward to having a new generation that goes beyond that.
And I think we really have to tip our hat virtually to Ray Douglas, Terry Smith, their group who really pushed this and saw the vision for this and has really advanced our field forward. So thank you.
Now, we're talking about this from the doctor's perspective. How about from the patient's perspective? What can clinicians tell patients how to manage their thyroid eye disease? What resources are available to them up to this point?
One of the things that we know from previous Delphi studies is that patients are incredibly observant. They're also very, very good at finding information either online or using their own resources. And they often come, at least a lot of my patients are more knowledgeable than some of their physicians who've, even diagnosed or been suspecting the disease. So patients are very good about learning about the disease and learning what are the triggers of their disease and their inflammation, whether that be even diet, but especially thyroid control, which is very important for their disease process and controlling their thyroid not being hypo or hyper. And then thyroid treatment, which also can exacerbate the disease depending upon the treatment modality. But they're also very good about understanding how the disease affects their function and their visual function, especially, the dryness aspect that becomes almost a rather severe chronic dry eye because the immune system, this process attacks the lacrimal gland also. So they're very good about choosing artificial tears, being able to lubricate at night, especially since they often cannot close their eyes. So I have to hand it to our patients. They often are very ingenuity. They have a lot of ingenuity in dealing with this disease process.
I think social support is really important for these patients as well. And that's what's been exciting about, as Ray mentioned, their social media. They're pretty savvy with social media. So there's been some Facebook groups that have come about. About 10 years, 15 years ago, Graves' Disease Foundation had a support group in several locations around the country. And so my patients gained, friends and colleagues there to learn about the disease, but it was very isolating. And so it's been wonderful to see them be able to share with each other. We built this, websites. We were each doing in our own little silo, building websites and, pamphlets for our patients, trying to educate them. And so it's just really been a boom recently in that regard. The other thing I think is important that we mention is smoking, because smoking can be known to exacerbate Graves' disease, as well as thyroid eye disease. And so helping the patients that are smoking, stop smoking, getting them hooked up. We have a QUIT program in Iowa, but there are local QUIT programs to get some support for that, or if they're around secondhand smoke as well.
Now in early 2020, the FDA approved Teprotumor for thyroid eye disease. Basically, can you explain what the mechanism of action for the drug in treating thyroid eye disease and basically how does it work?
So I think, instead of drawing some hand-waving scientific charts with arrows and cytokines and everything else like that no one's going to remember, I think it's always important to come back to the basic tenet of what we've learned about the tissue infiltration. So what we've learned is that the tissue, when analyzed from the orbit or the thyroid or other even extremities that's been infiltrated with thyroid eye disease, is that there's an overexpression of the IGF-1 receptor. And it appeared very early that there could be some autoantibodies that actually activate this receptor. And this receptor is also overexpressed on the immune system. So you have a receptor that's overexpressed, almost like your thermostat turned too high in your house, that's constantly potentially being stimulated. And then there was a very interesting paper that came out of Terry Smith's lab, and I was also involved in it, where the receptor is actually linked to the TSH receptor. So now you've kind of have two shots on goal, or almost a unifying theory that you have of the immune system, which is attacking these receptors and kind of turning up the thermostat too much on the fibroblasts and the immune cells. And so what we see waves of gene activity that recapitulate the disease, meaning that first you have a wave of inflammatory cytokines, and then you have a wave of extracellular matrix molecules. And this drug blocks that receptor from being turned on, essentially turns down your thermostat in your house, and it allows the cells to shrink and then to become in their normal metabolism. And so that's our best guess. It's always hard to know these. We don't have an animal model, but that's our best guess as far as the mechanism that we're dealing with thus far.
I also thought it was fascinating to read your article, Ray, about that the insulin growth factor 1 receptor is not only has a higher expression in the inflammatory thyroid eye disease, but the non-inflammatory thyroid eye disease. And so that just really was a great way to prove your point, like you said, that it's not necessarily just linked with the inflammation.
really think that these fibroblasts actually come from the bone marrow and then reside into the orbit and other tissue areas and continue to have this hallmark of overexpression many, many years later that is not genetically inherited, as we've examined twins in Denmark and shown that this is an acquired trait that occurs throughout life.
Basically, how is the drug administered to a patient?
It's an IV infusion that is given to a patient, typically at an infusion center. That infusion center can be in a physician's office. Like I think Ray Douglas has an infusion center in his office. It can even be done at home with a nurse. So it's an IV infusion every 3 weeks for 8 infusions. The first infusion is typically about 90 minutes, as well as the second infusion. And then it takes about an hour for the subsequent infusions.
And I think it's important to note that right now, most of us are doing 8 infusions, but that was because that's what the initial trials were doing. It will be, there are some studies that are ongoing now looking at different courses of infusions and durations of infusions. And I think that's going to be really interesting coming down the line.
So patients really go through a laborious treatment plan in order to correct thyroid eye disease.
It's interesting. I've not heard one patient complain about the process of the infusions. They are so, most of them are very distraught by the process that's overtaken their eyes, their body. And so they're just thrilled to be able to get a treatment that may be helpful to them. So I actually haven't had any complaints about that.
In comparison to receiving weekly IV infusions of steroids and then drilling out the bone between your eye and your brain, most patients don't mind the 8 infusions so much.
One of the things interesting about Teprotumor was that last year, due to the COVID-19 vaccine, there was a shortage of Teprotumor. Does that shortage still exist out there? Is it still a problem?
So that's true. In December, for us, it was December 18th when we found out about that their Operation Warp Speed basically shut down the production of many different drugs, and Tepezza was one of them. And that lasted quite a while. For us, it wasn't until about April of 2021 before we were able to start ordering and receiving Tepezza again. I think that there was some emergency use exceptions, but for the most part, at least at our institution, it was December 18th of 2020 to April 1st of 2021. But that shutdown ended in April and has never been a problem since. It is readily available. And what has happened, I think what happened during that 4-month period shutdown, at least in my area, is that it gave insurance companies a little bit of time to kind of catch up with this overwhelming need and request for Tepezza. And so some pretty clear guidelines were created by the insurance companies, at least in my area, which was kind of nice to understand really the criteria for patients to be approved, and which insurance companies will approve it and will not approve it for different phases of disease.
We were actually quite fortunate at the University of Iowa. I'm not sure if it was a smart financial decision or not, but had ordered all the Teprotumor for every patient that we had prescribed for. They had their whole course in stock already.
Great.
So we didn't have any disruption in our treatment protocols for any of those patients, but we were unable to start new patients during that period of time, but we've had no supply issues since.
We had a short-term interruption. We also tried to order in advance for our patients. So we had about a 2-month interruption, but none since. And interestingly, those patients did not, at least my patients and some early studies, at least anecdotally looking at the treatment response, those patients did not appear to have a reversal of their disease. And they appeared to kind of pick up where they left off, so to speak, as far as their treatment regimen and improvements.
It's good news to hear. It's good to hear it.
Right. Again, that goes back to the fact that we didn't have a lot of data behind the 8-dose, 8 infusion course, right? So this kind of forced us to see what would happen if courses were shorter. Sometimes
bad thing can turn they turn lemon into lemonade. It's good to hear. Teprotumor has been available for almost 2 years now. As clinicians and researchers, what kind of results are you experiencing in your clinics?
We did a lot of work with the clinical trials, and I infuse my own patients, so I see them each infusion cycle. And I think that our results, and we've published this with many members here, has been very similar to what we saw in the clinical trials. And that's often very difficult sometimes to achieve, because clinical trials are a unique animal, so to speak. But we've seen very similar results with about an 80+% response rate for patients with an improved proptosis and improvement of similar rates of double vision that have also been seen in the studies. So in broad brush, that's what we've been seeing at post-market.
Yeah, I agree with Ray, and especially in the patients that were studied in the clinical trials, those active, moderate to severe patients, it's really amazing how well they respond to this drug, and our results are very much on par with the clinical trial results. I think what's been more exciting is to find the patients that were not included in those clinical trials and see how they're responding to the drug. I just said yesterday, when I was talking on the phone with a patient who had been monitoring over the weekend because she had very significant sight-threatening thyroid eye disease, I told her I think the sweet spot for teprotumumab might actually be patients that have sight-threatening disease. It's amazing, at least in my experience, a form of the disease that I would typically treat with either extremely high-dose steroids or surgery, or typically both, is now responding so well to teprotumumab. And we don't have any randomized clinical trials, and there's still a lot of questions there, but it's exciting to see that patients that are losing their vision quickly from this condition are responding to teprotumumab as well. And we think it has to do with basically the way that it shrinks the muscle size and potentially the orbital fat volume. And so I think that's been really exciting. There have also been studies that have shown that teprotumumab is showing an improvement in proptosis and even double vision in patients that also have that chronic or stable form of disease. So while we don't have the same level of clinical evidence that the wonderful studies by Ray and Terry Smith and their group did in the New England Journal of Medicine studies from 2017 and 2020, we do have some retrospective data that shows that it's more than just the active, moderate to severe patients that are responding. And in my opinion, those sight-threatening disease patients are also responding quite well.
I would agree that it's striking that all the case series that have come out have all been pretty much in line with the randomized controlled trials, those phase 2 and phase 3 trials. I was part of the phase 2 trial, and I can tell you the first patient I had after the second infusion, I said, it's hard to be masked anymore. Like, this just doesn't happen. This change of proptosis to this degree doesn't happen, just on its own. Even with surgery, it's hard to sometimes accomplish that. This has been a game changer for my practice in the sense that my attitude and my patient's attitude have changed dramatically. I went into ophthalmology in particular because of thyroid eye disease, and it became kind of disheartened and kind of, I didn't enjoy it as much, the treating patients with thyroid eye disease, when I really didn't feel like I had a good toolkit. But I know that the whole landscape is changing, and whether or not we end up with this drug or another drug or some variation of it down the road, it's exciting to be able to, start treating these patients, and they're excited about it as well. So,
Dr. Douglas, this question is basically aimed at you. As you presented a paper at the 2021 American Academy of Ophthalmology, in which you examined the real-world adherence to teprotumumab. Can you outline your findings of your paper for us?
Yeah, so one of the major things which you gave a great introduction to is this performing the same as the clinical trial, in certainly a much broader patient area, and we're trying to get to that answer in several ways, and one of them was looking at the real-world adherence to the completion of therapy, and this involved taking several thousand patients which are currently enrolled on Tepezza, and looking to see how many of them completed therapy, and of those who did not complete therapy, why. So we found that the vast majority, well over 90%, about 92%, completed full course of therapy. And of the patients who did not, we looked at the adverse events as to why. And the adverse events, at least as far as prevalence, was very similar to what we've seen in the clinical trial. The good thing was that we really didn't see any new adverse events that were unreported, and they were similar in degree, as far as which adverse events were leading to discontinuation. And so I think that it begins to shape a picture as far as what we should look for on the adverse events, how we should focus upon them, how to overcome those adverse events. But also, we know that at this treatment course, most patients are following through. Can we go shorter, longer? How can we begin to adjust it, as Erin was beginning to allude to, moving forward? So at least gives us a little reassurance that that we're probably on the right track.
What Erin said is so true. It's so many papers from different groups are really saying similar things. The 8% discontinuation rate is something that we found in a different study, and the efficacy. I think we're all kind of finding that this drug is well tolerated. Patients love it. They do not want to be taken off, even if they're having some, mild to moderate adverse events. So I think we're kind of finding the same thing. So his work just continues to reinforce what we're seeing in our clinics every day.
I think that the risk-benefit profile also highlights how debilitating thyroiditis and disfiguring thyroid eye disease is, because I've definitely had patients who had severe muscle spasms, who had significant diarrhea, who had a change in hearing, but chose to continue with the medication because they were so pleased with how the medication was helping their eyes, and in terms of comfort, vision, and appearance. And so I think that it highlights the fact that yes, there's adverse events, but a lot of patients have chosen to push on despite those, which I think is really interesting.
You presented data on the efficacy of Teprotumor in thyroid eye disease patients with low inflammation, and how they scored in relation to those patients who were evaluated from the randomized trial. Again, could you discuss your findings regarding that?
Yeah, so it comes back to the underlying pathophysiology, that there's overexpression of the IGF-1 receptor. And we obtained most of these tissues during decompression. So they had very low inflammatory scores. That's just the nature of the research that was done over many, many years. And so, one of the things that's important is then to look at patients who have a low inflammatory score, or what's called a CAS of either 0 or 1, and to see whether they responded. And that's exactly what we did outside of the clinical trial. In addition, and they responded quite well. One of the things we also did was to kind of look at the IGF-1 receptor levels in patients with high inflammatory disease, low inflammatory disease, and normal, and found that it continues to be overexpressed compared to normal. So I think relatively straightforward, but beginning to probe outside the narrow clinical trial guidelines. And remember, when we designed the clinical trial, it was what's going to give us the cleanest answer, and how can we coordinate 20 international centers to all agree. And so the clinical trial has some very narrow guide rails, for that purpose.
Kossler and Shriver, are you experiencing the same efficacy as Dr. Douglas reported in his findings? Are you experiencing that in your clinic as well?
I haven't been using the Teprotumor in patients with a low CAS score. I've been waiting and seeing what everybody else is doing. So I'm letting Ray and Andrea help clear the path for us. At times I've had some difficulty getting approval for Teprotumor, so I've chosen to stay within more of that narrow range. I have been treating chronic patients, but I haven't necessarily been treating the lower CAS scores. But that's why his recent papers have been so interesting to me, that it's making me think again on whether I should start pushing the envelope and asking for approval on those. So I really appreciate them delving into that. But no, I haven't worked with patients with Teprotumor on low CAS.
So let's see, in 2020, I actually was part of a paper with Ray and others where we looked at patients that had, more chronic low CAS disease. And we did find that there was significant improvement in the proptosis and even the double vision on par with the clinical trial. So I haven't actually looked now at my patient population in the last year or so, but I do think that it has a role in chronic thyroid eye disease or in non-active thyroid eye disease. I think that we just need to do more studies like Ray is doing. And we also really need to look at the durability of the effect. So there's still a lot of questions that we don't know, but I definitely think that it works, particularly for patients that have significant proptosis. The more proptosis, typically, at least in my clinic, the more response that I'm seeing. I don't know about, maybe Ray has more information, but for patients that have really significant double vision, like significant restrictive strabismus, Gorman diplopia score of 3, and that's really their main finding. I haven't seen that go to a 0 yet in my clinic, but I've certainly seen patients that have a Gorman diplopia score of 1 or even 2 have improvement of their diplopia. So again, still in things that we need to study and look into to really see not only who might respond, but who has a very high likelihood of responding and then retaining that improvement.
Okay, Dr. Shriver, this question is for you. Your group recently had a case series accepted for publication on active chronic thyroid eye disease. Some of those patients were previously treated with radiation and other biological agents. Can you provide a summary of your findings and what you've learned from these cases?
Thank you. We're at a really interesting time because I feel a scientific and ethical obligation to publish, even though I don't have the numbers of Dr. Kossler and Dr. Douglas in terms of my patient that I've treated. I feel an obligation to publish what I've done and who I've treated because of this issue of getting the data out there, teaching, let's figure out where it's effective, and also helping for insurance clearance and insurance approval, which patients, should we cover this on? We're going to get to it later, but the drug has a significant expense. And so trying to figure out when we can use it most effectively, I found was important. So there was the paper on the low activity chronic patients, but I felt like there was more room in the literature for active chronic thyroid eye disease. So we just published our series. We had 6 patients, and 5 of them had completed all 8 infusions, and 1 had done 6 infusions. The average duration of the thyroid eye disease was 10 years. And we found, consistent response as with the phase 2 and phase 3 trials. Proptosis reduction, 3.8 millimeters, CAS reduction, 1.5. I think the most interesting patient, who actually the pictures will be in, we tried to write this as a letter to the paper in Eye, but they said they didn't need it a letter, they wanted it as a brief report. So we're going to have it as a brief report. And there's a picture of a woman who's had thyroid eye disease for 80 years. She was treated with steroids, radiation, decompression. She'd had lid retraction repair on 3 lids, and she had a reduction in proptosis of 3 millimeters. Her CAS remained stable, however, but her eyelid retraction improved significantly. And 6 months out, she's still doing very, very well. So she's an example of somebody who would have thought she'd respond that well despite the eyelid retraction repairs, despite the radiation. So I thought that it was worth getting that out there. And then on the other hand, I had a woman in her 40s who had a history of thyroid eye disease for 8 years. She'd been treated with steroids, tocilizumab. She was interesting because her proptosis improved and stayed improved, actually got down 4.5 millimeters, but her CAS rose 3 months after the infusion. So between 3 and 6 months post the infusion course, her CAS came back up and her lid retraction came back up. So that one highlighted for me, one, the importance of our getting out 3-6 months, more long-term data and long-term follow-up, but also how we have to start talking about these patients who've been through the gamut, they've been through everything. Can this help them? And I really think there is potential for that as well.
Erin, how are you defining the active chronic patients?
But just a CAS score greater than 4.
And then what makes them chronic? The time period, or?
Yeah, the time period. We were using the same criteria as your paper with over 2 years.
Interesting.
What I think is great about the studies too is that everyone has their own practice, and different geographies around the country have very different forms of thyroid eye disease. I mean, it sounds a little strange, like why would that occur? But certainly when I was practicing in Michigan, my patient population and treatable patient population is very different than in California. And so I think what's great is that you have people participating and giving a very unique perspective, because their patients are very unique, and their risk-benefit ratio and everything else like that also really contributes to this early learning phase.
That's a very good point. We think about it regionally, like, well, Europe, they have low selenium in their soil and selenium deficiency, so that's why they're different, or they smoke more in Europe, or that kind of thing. But I hadn't thought about it regional within the United States. So thank you for that.